Did we start it?
Yes, we have started.
Hello,
People are
everybody.
slowly connecting.
Hello, everybody. Happy New Year to all of you. Kindest regards, and hopefully it will be a great year for all of us and for our beloveds, of course. Today we're gonna make the first webinar of EANS Task Force, and I think that this is the first webinar of EANS. So we are starting the year with our task force, with the new technologies, with the innovations in neurosurgery. Unfortunately, we have a change in the program. Our invited speaker is a neurosurgeon, of course, and he has an emergency case, so he cannot participate, and we have to make some kind of improvisation because this was really a last-minute change. So today we're going to speak about Circ robotic arm and the two versions of the Circ robotic arm. I think that the topic about robotization in neurosurgery is core for our task force. So I think it will be an interesting presentation, and the most interesting part, I suppose, will be the discussion after that. So this will be our presentation. But before all, I would like to start with a very brief review of last year and of our activities from the last year. I would like to share my screen. Okay. So last year we had several very interesting webinars. We started with in the month of February with a very interesting topic, and this was the topic for the artificial intelligence and the academic and clinical implication of large language models, the plagiarism, the text generation, and data extraction. It was our colleague Majowski from the Czech Republic that was invited speaker. Then we had a webinar that was dedicated to customized implants in spinal surgery. It was moderated by Enrico Tessitore, and we had two invited speakers, one from Italy and one from Karlsruhe Institute of Technology. Next topic that we had was related to advances in spinal navigation, augmented reality, and optical methods. The moderator was Victor, and we had an invited speaker from Karolinska Institute, Adrian Terrander. Then we had in September a very interesting discussion about the cooperative robotics. Aria Nabavi was our invited speaker from Hanover, and he discussed the technical advances, concepts, and ethical considerations of cooperative robotics. And today we had invited Timothy Smith with a very interesting topic, digital phenotyping in neurosurgery. I had the occasion to listen to one of his presentation regarding this topic, and I think that this is something very important and extremely interesting. In fact, his discussion was mainly about the wearable devices and how can we use these wearable devices, including our phones, for follow-up of our patient, for the new applications that exist of these wearable devices, and of course this phenotyping that can be done with all the measurements that these devices can perform on an everyday basis. So I'm sure that in a close future we will have him again, but as I said, unfortunately, he's not. It won't be today. It won't be today. He has an emergency case. So this was in brief the year. Of course, we had a nice meeting in Sofia. I hope that most of you enjoyed, and we discussed there also a lot of advancements in the new technologies. We had invited speakers, keynote speakers, who discussed the development of artificial intelligence, the influence of artificial intelligence on contemporary medicine, and particularly neurosurgery, etc. So I think that this was a good year for our task force, and hopefully 2025 will be even better. Now I would like to go to the topic that we decided in the last moment to present today, and this is a comparison between the two versions of Circ robotic arm. And I will try to answer the question, is this a new version or a new tool? So I have nothing to disclose regarding this presentation. Regarding innovations in neurosurgery, we are trying to do several things thanks to innovation, to do a safer, a quicker, and a less invasive surgery. And we are doing this thanks to different types of innovations. One of these type of innovations, of course, is robotizations. Robotization, the robots as a word has been introduced by the Czech author Karel Čapek in 1921. A robot means it comes from the word from work, a robot, work. And basically, these are machines that are resembling humans and are trying to do different type of and are used mainly in industry to make precise, repetitive tasks that need a lot of force, physical force, more than the human force. In surgery, we rely on robots mainly because of high precision, and if we do need to repeat something a lot of time, of course, robots have a lot of advantages. And last but not least, this is endurance. We know that as humans, we have our ergonomic problems during surgery, we have our fatigue during surgery, so endurance is also a very important advantage. Robotization has started in neurosurgery in 1985 with the Puma robot that was used to perform a CD-guided brain biopsies. Then we had a prototype of Da Vinci system in 1997, but the truth is that the Da Vinci system has made an enormous development, but unfortunately not in the field of neurosurgery. We all know that nowadays in urology, in abdominal surgery, in obstetric gynecology, this is almost Da Vinci system has become almost a standard, but not in neurosurgery. Nowadays, we have multiple different platforms that are related to our specialty, to cranial from one side and to spinal surgery on the other side. There are usually two modalities, master-slave robotic systems that are similar to the Da Vinci, and there are positioning robotic systems that are mainly in spinal surgery and mainly for transpedicular fixation, and this is what we're gonna discuss mainly today. So when the robotic platforms are using 3D registration into the coordinate system, we know very well this from the principle of neuronavigation. We use different type of intraoperative 3D C-arms or CT scans, and then we are making a 3D intraoperative 3D model of the patient, and using the camera, usually an infrared camera, we navigate the robotic system, and this system will guide us mainly to place screws. There are different systems. We know the Maser Renaissance, which was one of the first with mechanical guidance unit. Then we have active robotic arms. We have different systems that are evolving very fast. And by the way, also an important part of this is that a lot of companies have been bought from other companies for the last year. So this is a field that is very dynamic. And we have the passive arm. This is the Circ BrainLab arm that I'm going to discuss because we have experience with it. The BrainLab Circ robotic arm was introduced in 2019. The first version was around 11 kilograms, and it was a mechatronic arm with full range of motion. You can see it on the left on your screen. And it was the second version was semi-active. So for the second version, we have an additional module that can do active movements, and from one side, and from the other side, you have the passive arm that need to be moved by the neurosurgeon. So the second generation is compatible with standard operating theaters. It's AI-based planning. There is an AI-based planning of the screw placement. So the system will suggest you how to put the screws. You have, of course, to to give you confirmation. But by the way, it's an extremely accurate suggestions. Usually you can receive extremely accurate suggestions. So the arm is more stable, you have better stability, and you have some LED signalization that is giving you sign if there is any movement or any change in the trajectory due to breathing or something like this. And there is the possibility with the semi-active, with the active module for automatic alignment. So this is more or less how it works. You put the reference, a reference with a reference star guiding instrument. You can check for the incision with the navigation where to place your incision if you are performing minimally invasive procedure. Then you position the arm around the trajectory that you want to have for your screws, and the automatic module will do the rest by positioning it itself very precisely over this position. As you can see on the left, there is this is the suggestion that has been made by the system, by the AI of the system. It is a very precise and very good trajectories that are usually suggested, but you have to confirm them. So this is how the CIRC module is mounted. It's on the operating in the operating theater. The reference star we used to have a 3D registration with a 3D C-arm. Now we have, fortunately, for the last month, you have the last generation of intraoperative arm of BrainLab that can do this job much more precisely, much quickly, and of course with much more details. So this was the first module when you have to position the arm and to choose the right trajectory looking at the screen. So this is basically a navigation, and when you find the trajectory that you want to have, you block the arm in this position, and you do the rest as unusual, cannulated transpedicular screw fixation. You put a K-wire, and then you put the screws. So the main advantage here is that you can position very precisely, to choose very precisely your trajectory. And when you find it, when you block the mechatronic arm, you have a very good stability for the rest of the steps that you have to make. So this is a very nice, very quick, very ergonomic tool. And this mechatronic arm was, I really like it to use it because it was introduced in a very natural manner in our workflow, intraoperative workflow. So regarding the automatic alignment, of course, I have problems with my video, but we have with the second generation CIRC arm, we position the CIRC arm around the trajectory, and then the CIRC arm by itself is doing the rest. So the last movement are performed by the active module of the arm. Then you have a green light, green signalization that gives you a sign that the module is in the right position, and then you continue as an usual transpedicular cannulated fixation. So this is how it looks. In reality, you see how you position the module around the pedicle, somewhere around the pedicle, and then the module will make the detailed position by itself. It's very quick. It's bigger as an unit, so you have to. It's stronger as an arm, and then as you can see, you have the final positioning and the green light signalizing that you are on the right position, and you can continue with the cannulated pedicular screw placement. So there are some numbers that I don't want to discuss in details, but of course we have more experience with the first arm than with the second. With the second, now we have much more than 21 cases, but we have more than probably 60 cases now. But we can say we have enough experience to overcome the initial learning curve that, of course, is present for every new tool, and we can make a nice comparison between these two tools. What can we do? We can do what can we say? We can say that the mean time for X-ray exposure is almost the same. The mean time per screws was longer in this initial series, but I think that this was due mainly to the learning curve. As I mentioned, this was only the 21 first cases that we have made. Now we have become much quicker. Despite that, I think that the second version is slightly slower because this positioning and the automatic positioning of the system is somehow slower than us as experienced spinal surgeons when we are looking for the right trajectory. What can you say about the advantages and disadvantages of the second version of Circ? The advantage is that it's easier. There is an easier screw planning. In fact, screw planning is not present in the first version. So this is a new advantage, a new possibility for this mechatronic arm, robotized mechatronic arm. We have more rigid fixation. We have probably better precision, and we have an easier learning curve. What I can say is that, in fact, my young neurosurgeons have become very familiar with this tool. For me personally, having the freedom to choose the right trajectory was a great advantage. But for surgeons that have less experience in transpedicular fixation, the possibility to have a screw panning and to have this fine tuning and automatic finding of the right trajectory is a great advantage. From the side of disadvantages, I would like to say that it is slightly bulkier, which can be a problem with these patients. And if there are higher amplitudes of breathing, this can pose some problems. And at least in the beginning, we needed a little bit more time per screw. But I think that with the learning curve that is quite steep, we can have almost similar time as the first version. So the minimally invasive spinal surgery concept is to reduce the soft tissue trauma, to have less pain, better functionality, and at the end, faster recovery of the patient. I think that this navigational robotized arm are giving very good advantage in MIS mainly. And as a conclusion, I would like to say that robotics in spine surgery is feasible, first of all, at least as accurate as fluoroscopic guidance. We made several investigations on this, and we have some publications in Brain and Spine related to this. They are safe for pedicle screw placement. They are very consistent regarding the correct trajectory of screw placement because there are less failed or suboptimal screws position. There is a better biomechanical stability, which is very important, especially in cases with the patient with poor bone quality. They can be performed by surgeons that have less experience in this type of surgery. And I would say that this is a very important point that I would call a democratization of this technique. All of us knows that once, in the past at least, to start putting pedicle screws, you needed a lot of hours in the cadaver lab, a lot of X-ray exposure, a lot of time, and a lot of experience. Now, even surgeons in their first years of practice can appreciate if the trajectory is good, and the robotized arm is doing the rest by itself. So it's really a democratization of this knowledge. It's easier and more relaxed for the surgeons, and with the reduction of X-ray exposure is very important, at least for the team. And we have a better interoperative orientation that is important in cases for MIS surgery, cage insertions, osteotomies, etc. So that's it in brief. My presentation about these two tools. So for me, the first version of CIRC is very good for more experienced surgeons because it's slightly lighter to use, I would say. And the second version is perfect regarding the suggestion for the trajectories that are given with the AI and regarding the possibility to be used by less experienced surgeons with this fast positioning in the right trajectory. Thank you. So, is there any opinions on this, Nicholas? I know that you have a lot of experience with different systems for robotization, for spinal surgery. So what do you think on this topic?
Wonderful presentation. Thank you very much, Nikolai. Oh, it is amazing. And I would like to ask your personal opinion in 2 points. First, the question that is used to come often is if you find any advantages of navigation only as compared to, let's say, navigation robotics. That's my first question.
My answer will be definitely yes. Definitely yes. Navigation, of course, is very useful, but with navigation, we can find your entry point. You can look for your trajectory, but it's not fixed. The trajectory is not fixed. The great advantage of these two systems is that you have a fixed trajectory, so you can put your K wire in a very precise, you can drill in a very precise manner, you can put your K wire in a very precise manner. So it's much more, I would say, it's a completely different level of security that you can obtain thanks to these robotics arms. So for me, the advantage is clear, and the answer to your question is yes. Definitely, I would prefer to use a robotic arm.
And the second question is related to, although we use navigation plus robotics, you may have some very few cases, but some malposition of pedicle screw, usually to the lateral position, and this is due to the skiving of the entry point. So that can drive, of course, usually intraoperative revision, and very rarely redo surgery, which is extremely infrequent in the general experience. I think your experience is the same. But what if you have any personal tricks to avoid this problem in relation to the management of the entry point, the first contact of the instrument with the bone?
Yeah, this is a problem when you have a lot of osteophytes. Sometimes you can the guide may slip slightly aside. It is possible. So what we have done, probably it's off-label, but it works quite well. So we don't fix this guide. We don't fix it to the robotized arm. And when it is in the right position, we slightly hammer it. And because it's and this is when you hammer it a little bit, and you open the cortex in this manner, and you fix the entry point. And if there are need for a slight correction, this is the right moment to do it with slight flip to one direction or to the other. But by hammering slightly, you open the cortex, and in this manner you fix the entry point, and you can very gently, if necessary, change the trajectory. So this is my personal way to do it, and I think that yes, it works quite well. The other thing is that we use an automatic drill. When you drill by hand, it's slightly slower, and the movement of your hand can slightly change the trajectory. When you use a power drill, it's very fast and it's much more precise. So these two things I would suggest as tips and tricks for having better and more secure trajectory.
Absolutely. And we have a question from the audience here about beyond your opinion, if you know of comparative studies looking at this difference of navigation versus robotics.
I'm not sure. We have made our study that was comparison between robotized and traditional way for putting screws. So our result was more than clear that there are at least that navigation and robotized putting of screws is at least as good as fluoroscopy navigated screws. But I have to be sincere, despite that I have experience in putting screws, and I started this now probably more than 15 years ago, putting screws or even more. In some cases, especially in challenging cases, it is a great advantage to have navigation, and it is a great advantage to have a robotized arm that can fix. If in some cases you have, you need a very precise trajectory, and even if you are experienced, you cannot do it always by fluoroscopy, and you with this fixed trajectory and with this mechatronic arm, you can obtain a very good stability and maintain a very good trajectory. So for me, there is a great advantage in precision.
Enrico, please, want to comment on?
Yes. Hello, dear Nicola. Thanks a lot for the presentation. Before we move to another question from the participants, I just have one or two comments. First is that I find this tool extremely helpful, and actually the precision and accuracy are both ensured by these robotic arms. Although there is still a risk of skiving of the cannula, as you're mentioning, most of these robotic arm, they also provide some specific tool like a high-speed drill can be inserted through the robotic arm in order to prepare the entry point. Despite that, it's very important when you select, you plan your screws to select a flat surfaces if possible and if available, in order to reduce the risk of skiving, because although you are sticked by the robotic arm, there is some freedom of movement of the drill inside the arm and the robotic arm. So this is very important to have a correct planification and try to avoid any bony spurs or sliding surfaces when you insert first the screw. This was my comment. The second was a question to you. This is a bed-mounted system, if I'm not wrong. And how do you deal with the relative movement of patients compared to the arm, relative to the arm, as soon as you apply a pressure on the vertebra to navigate, and this is not how do you say, aligned with the movement of the robot? How do you deal it?
It is a problem, but it depends on the level. On lumbar level, usually the breath movement are not so so strong, I would say. So usually there is no problem there. Of course, after putting the K wires, we always put the K wires and then we make an X-ray control. So you need to make an X-ray control to be sure that you have your trajectories have been good and everything is fine. It haven't happened, but usually when you acquire the 3D image, you need to stop the breathing of the patient for a brief period of time, let's say for 20 seconds. Usually you need around 20 seconds to make the 3D imaging. So you have to stop the breathing of the patient during that period. Of course, before that, you can higher the level of oxygen saturation, and then you block the breathing for 20 minutes, so you don't have additional movement and movements, and you have a more precise 3D image. But this is what we do. Usually we, of course, if it is an open surgery, you can see very well, and you can touch with your finger if the entry point is correct. So more or less, you can have your digital with your hands
Haptic sensation.
control, and then you have an X-ray control to confirm that your KORs are well placed.
Thanks
Okay,
a lot.
Alessandro.
Going to the
Alessandro has a
yes, there is a question from Nicolas. There is a question from the participants in chat. What is your opinion about electromagnetic tracking versus optical tracking? Because we know that this system, the limitation is that they are based on camera and a camera tracking concept, and can be a source of inaccuracy if there is a interruption of this line of view between the camera and the reference array. Have you tried other system? This is the question to you.
No, unfortunately, I have not with electromagnetic navigations. I don't have experience, so I cannot make a comparison. Indeed, in some situations, especially if you have an obese patient, the reference star and robotic arm may interfere. So you need some kind of experience to reduce the situations when you have such type of interference. So it's there is some kind, I would say, of learning curve, especially in obese patient, but it's not so frequent, I would say. So usually it works quite well and without important problems and challenges regarding this visibility of the reference time. Alessandro?
Alessandro.
Yes. Apologize for my voice. Unfortunately, I'm in the middle of a flu. But first of all, thank you very much for being able to fill for Professor Smith. And my question for you would be, you said that the initial trajectories of the screws are informed by an AI-based model. Do you know, maybe talking to the robot representatives, if this how is this model developed? Is this based on a panel of experts providing information about the ideal position of screws and then having the software suggesting it to the surgeon?
I have no idea how it works, to be sincere, but the result is very good. I mean, in most of the cases, you receive really good suggestions. By the way, I would like to share with you something else that regarding this robotic arm can be interesting. It's not only transpedicular screw placement, but we had some cases of very challenging cases of vertebroplasty with very flat vertebra or with very changed, not normal trajectory, or with very poor bone quality. And we made several vertebroplasty guided with the robotic arm. And I think that this could also be an indication, of course, in a very limited part of the cases and the situations, but especially when you need to go to a very precise point of the vertebra. If you have a metastasis, if you want to go in the core of the metastasis, it's not always a traditional trajectory that you can use. So navigation and robotic arm here also can be very useful. This is just something that we had in our practice, and I'm adding it as an indication for using this type of innovation and navigation.
I would like to comment something in relation to the previous question of one of the attendees regarding the comparison of precision of navigation versus robotics. And I think that the traditional way that we measure precision is, the position of the screw in relation to the pedicle. But I think that in the literature and with the new technology, we are shifting from measuring the position of the screw in the pedicle to the relation of the preoperative planning to the actual postoperative image of the pedicle. And that's where you see difference between navigation and robotic. If you use the traditional methods, which used to be the Gershwin-Robbins scale, it's difficult to improve the 98% precision of navigation, I think it is. But if you compare the mismatch of the plan with the actual postoperative position achieved, you see a significant difference in favor to robotics. The other comment is on the alternative. I think they say electromagnetic tracking system as an alternative to optic tracking. And I think the problem with the electromagnetic is the interference, because spine surgery is done with a lot of metal and the hardware, and I think that the electromagnetic tracking is being used, for example, in full endoscopic techniques for anatomical location, as far as I know, but not in pedicle screw surgery or in open spine surgery. But it's interesting to think about alternative techniques of tracking system.
I would like to underline once again that for me, one of the very important advantages for us is this type of democratization of this technique. Putting screws is quite complicated, delicate, and we know that we may have disasters if we don't place the screws in the right way and with the right trajectory. And these two give us additional security and will permit to a surgeon to start putting screws, not, let's say, after 3 or 5 years of education, but much earlier and with much more precision and security. So for me, these new technologies are important with this democratization that they gives. And in fact, if the production, I would say, of a spinal surgeon putting screws was 5 years, the production time, or 10 years, now it will be much shorter, which is important for the whole system of healthcare and of neurosurgery. I'm sure that these devices will become more and more popular. Probably one day we'll have the possibility to drill also and to remove part of the bone, at least with robotic arms or something like this. And for me, it was important that only for a 4 or 5 year period, we had a big change and big evolution in this arm, from the first to the second generation in the capabilities, AI capabilities and active capabilities. And if we see this only in the period for 2-3 years, imagine what we're going to have in 5-10 years time from now, counting. So I'm very optimistic, and what I'm sure that in 5 or 10 years we're going to do a completely different type of spinal surgery, and we have to be prepared for this, more or less. I think that EANS, with all these discussions, is doing this, is preparing ourselves and our society for the future that is coming quite fast, and that will change the way we help our patients. Now, because we are at the end, I would like to say something else that I missed in the beginning. I wanted Alessandro to present it, but we have a very difficult first webinar. Timothy has an emergency case. Alessandro is ill, unfortunately, and has problems with his voices, but I would like to share my screen and to show you that EANS has, thanks to the efforts of Alessandro, has its first publication in Brain in Spine, and its knowledge, interest, and perspective on artificial intelligence in neurosurgery, a global survey. Alessandro, of course, was the main author and the main generator of the idea and everything. So thank you, Alessandro, for this great support for our task force. I think that this is a very interesting and important article that you have made, and survey that you have made. I will just briefly read the conclusion. There is a low familiarity with basic AI concepts in the neurosurgical community. Nevertheless, there is a strong interest and positive attitude toward AI implementation. The systematization of training and the production of education resources will be key in guaranteeing a successful implementation of AI in the evolutioning history of neurosurgery. I think that this is a very important message for all of us. And I really advise all of our visitors to this webinar and all our friends to review it carefully, because it's clear there is an interest, there is a very rising development in this field, but we are still not prepared, we are still not knowledgeable about the details of AI, about the different the terminology, the different notions, and we have to catch up. We have to catch up because things are changing very fast, and we have to be prepared for this future. As in spine surgery, generally speaking, in neurosurgery, I think that things will be completely different from point of view diagnostic, point of view decision-making, point of view documentation, even if you want, only in 5 years' time. So we have to push our boundaries and to enlarge our knowledge. And I think that EANS Task Force is one of the places when we can do this. So is there any other questions? Okay, thank you very much. It was an emergency decision for this webinar, but I hope it was useful and interesting for all the attendees. We continue this year with this activity. Webinars will be our main, of course, activities. You can expect new and interesting topic regarding the emerging technologies and innovations in neurosurgery. All the best to all of you and your beloved for the whole year. Hopefully to be healthy and beneficial for all of us. Bye-bye.
Bye-bye.
Bye, everybody.